Good evening, all, to the 129th session of the Weekly Huddle. I am your host, Anoop Agrawal, and joining me today is my friend and co-host, Praneeth Polamari. We both are cardiologists working at KIMS Hospital. Before I start today's session, I just want to share with you just a small tidbit about the Weekly Huddle. We have been doing this show for almost 2.5 years now. And other than the first 8 episodes, which we were not recording at the time, from session 9 till the very last episode, we have been recording. And this session is also getting recorded as we speak. All of the recorded sessions so far have been uploaded on the YouTube and the podcast Castbox. And YouTube just alerted me today saying that the cumulative views on those 120 some videos have crossed 5,000 last week. Now, 5,000 in the YouTube view count is very, very tiny, particularly when we are talking about 120 plus videos. But I get this solace thinking all those 5,000 are doctors or healthcare providers. So that definitely is something that I would think it is getting channeled to the appropriate audience. We did accumulate approximately 2,000 listenings on the podcast as well, with a total combined viewership of around 7,000. So a very little drop in the vast ocean of YouTube, but I'm hoping that offline also there are going to be colleagues, seniors and juniors who might get benefited by listening to some of the discussions that we had. Having said that, I am going to go with today's case discussion. And to navigate us through our discussion, we are joined by Dr. C Gupta. He is the head of department of vascular surgery at Care Hospital, Banjara Hills. And we have had him a few times before, and every single time when Dr. C Gupta was there in our session, that session turned out to be a blockbuster in terms of getting his insights on the vascular aspect that we are going to discuss about. So I will walk you through the case. I will ask my colleague Praneeth for his initial impression. We will go around discussing with some of my attendees. And then finally, I'll ask Dr. C Gupta to correct us where we went wrong and also give his insight on the case today. So this is a 62-year-old female. She has history of diabetes and hypertension. Both were diagnosed last year, and they both are reasonably controlled. In fact, they were never bad at the time of diagnosis also. She came to my OPD with 2 months history of gradually progressive leg swelling. And this is the story that happened last week. So it's an evolving clinical case as to speak. So at that time, she said she had been noticing this leg swelling going on for about 2 months now, gradually getting worse. She definitely says that the swelling is more towards the evening, and it kind of resolves when she wakes up. It's almost 70-80% gone. She still has got some swelling, but it definitely accumulates over the day. She does complain of mild dull ache on both the legs. They are not at the joints. They are pretty much diffused throughout the leg. Other than that, she does not have any other associated symptoms. And you can ask me if there is any particular element of history that you want. But when I asked her, she didn't complain of any other symptoms. On examination, she does have 2+ pitting edema on both the legs. Her left leg to me seemed like a little bit more swollen than the right side. And there was some warmth and induration over the left shin that I could appreciate. There was no any obvious ulcer. There was no any obvious gross tenderness that I could appreciate. I also could not appreciate any obvious varicosities. There was hyperpigmentation, which was noted on both her feet, and they were extending just a little bit higher than her ankles. This was there on both the sides. And she said these hyperpigmentation also have been there for quite some time, not particularly 2 months. But she says this is there for quite some time now. On examination, she also has got systolic ejection murmur. Her lungs were clear and her abdomen didn't have any tenderness on palpation. She's taking low dose of metformin, sitagliptin, and telmisartan, and with that, her sugar and blood pressure are reasonably controlled. Actually, she saw a general physician before she came to me. So by the time she came to me, she already had some workup which were done. And I have listed that workup on the WhatsApp group. I'm going to read it out for you. But in case if anyone wants to review that, you can look into the WhatsApp group for the huddle. So the initial workup included mild anemia. Hemoglobin was 10.8. Her renal function test, urine analysis, they were all normal. Her ECG suggested LVH with strain pattern, echocardiogram, and that was the reason why she was sent to me, actually. Her echocardiogram showed good LV function with LVH. She had moderate aortic stenosis with a mean gradient of 28 millimeters at the valve level. She also had an ultrasound abdomen, which showed no sonographic abnormality. Now, all these tests were done at an outside hospital. So I didn't have the pictures to review. I'm just telling you what the reports that they said. She also came with venous Doppler of both the legs. And I'm going to read out the Doppler report because that is going to be relevant in today's discussion. So the report read as negative study for DVT. SFJ and SPJ showed no reflux in standing position in both the legs. Reticular veins were seen in both lower limbs. Diffuse subcutaneous edema was seen in both the limbs. Bilateral benign reactive inguinal lymphadenopathy was seen. Varicosities were seen with prominent perforators in the left lower limb. One perforator was identified at 5 centimeters below the knee, and the second one was identified 15 centimeters below the knee, both on the medial aspect. So that was the overall venous Doppler report that she had. She came to me primarily, I'm guessing, because her physician sent her looking at the aortic stenosis part. So the discussion point that I want to bring with today's case is what should be the initial approach towards leg edema, focusing mostly on the investigation that she got so far. Is it a standard order set, or are there some other thought process that you would suggest as the initial approach? Then these combo presentation that sometimes you have edema with or varicosities, cellulitis, how do we differentiate the two? Because many of the times early cellulitis can present as acute DVT as well, where you can have tender leg and you can have the aching pain. So how do you differentiate these two, and any other diagnostic assessment that you do? The art of ordering and interpreting venous Doppler, because I think this is one test that does require a little bit of understanding rather than taking it at its face value. And the treatment considerations related to swelling, related to pain, related to varicosities, related to cellulitis, related to whatnot. So all of these we want to discuss. And of course, because two cardiologists are leading this discussion, we are definitely going to talk about heart in this whole aspect. So Praneeth, if this patient were to come to you, please walk us through how do you take care of this, your comments on the discussion points, and then I will ask the rest of my attendees for their comments.
Yeah, no. So a patient presenting with pedal edema, I would try to first see whether it is a local cause or a systemic cause. Coming to systemic cause, when we talk about organ dysfunction per se, to begin with, as a cardiologist, will be one, heart failure. I would try to poke into symptoms and equally try to find signs for heart failure. She doesn't seem to be having any classic features. You mentioned patient is having a moderate aortic stenosis. Though it is not severe, sometimes even moderate aortic stenosis can present with heart failure. But the way you described me doesn't look like a heart failure. But I would still try to uh, justify by doing a BNP just to make sure that heart failure is not the cause for her issue. The other organ dysfunctions being renal failure, and the other being liver dysfunction. If the patient is having adequate urine output and does not have any other issues, things should be okay. And I would try to look at her creatinine and probably proteinuria in her urine to see whether that can explain her pedal edema. Liver, try to see whether liver is the cause for issue, history of any jaundice or any other stigmata of liver failure. I would try to look into it. Endocrine issues, thyroidism, hypothyroidism is something which can again cause, may cause pedal edema. So I would probably rule out that one. So these, in my opinion, are the systemic causes. You mentioned about anemia, hemoglobin is 10, not so severe. So less likely that this patient can have anemia causing pedal edema, but severe anemia sometimes can cause pedema. So in her case, pedal edema is ruled out. Now talking about local causes per se, I would try to see that venous system abnormality is something which can cause edema, particularly venous hypertension. Now, venous hypertension can be obstruction at the because of vein thrombosis or other abnormalities, maybe because of a previous injury or anything which leads to inadequate flow and leading to venous hypertension can cause pedal edema. Sometimes in an incompetent valves, incompetent perforators, and incompetent valves as a part of post thrombotic syndrome can also produce pedal edema, which can be known by a color Doppler. But as you mentioned, it does not seem to be showing any significant abnormality. The other cause which can equally affect pedal edema is inadequate lymphatic system. So if the patient had any previous history of any insect bite or any history of any uh, this location in tropical injury and any history of this filariasis, something that I would try to poke into. You may not have a obvious full-blown elephantiasis of the leg, but still sometimes minor form can still produce some pitting pedal edema, which typically can go away in the morning after lying down and can come back on prolonged standing. Other issues as a cardiologist, which I would try to look into it about the drugs, whether patient is taking any calcium channel blockers, which can produce pedal edema, or any other drugs, which can produce the fluid retention, something like pioglitazone for diabetes and other things. So I will try to look into her drugs, what she is taking. Now, further investigations, few of them, as I mentioned, which probably you already did. So, if things are not there, whether she has any systemic infection or an inflammation which is causing, or local infection or inflammation which is causing her pedal edema. Yes, you mentioned there is some element of warmth, but per se, the way the history has been mentioned, the cellulite seems to be less possibility for me. I expect the patient to be having some element of fever and equally redness or other things other than some warmth. I could not get a feeling that the patient is having cellulitis. The treatment per se, this condition looks benign to me, and I would suggest this patient to use some stockings and avoid those prolonged standing situation. I think in one of the sessions we at length discussed about the compression stocking. So in her case, maybe a level 1 compression stocking should probably be sufficient to get comfortable. And I think we can reassure this patient and not worry too much about the pedal MRI. That is how I would approach this patient, Anup.
So, Praneeth, in your answer, there were a lot of what I would say, there were a lot of if and then and what. You have a case in front of you, you have got certain labs, you have got echo findings. Based upon the information that I have given you, uh, have you excluded cardiac dysfunction, or would you like to do some test for this?
I have almost certainly ruled out. Uh, mm, uh, yes, I have almost ruled out the heart failure in her.
Have you ruled out renal dysfunction, or would you like to do some more testing for this?
Ruled out.
Okay. And then how about the infection part?
Infection also, I do not think there is any evidence of infection. I don't think there is anything serious going on in this patient. I would reassure her, and if that pedal edema is bothering her, I would ask her to use some compression stockings and get along. And if the symptoms continue or progress, then I may poke further. But for right now, I don't think there is anything serious going on with this patient.
Perfect. Thank you so much, Praneeth. I'll move on. Shankar sir, I think you can give us more insight about patients like these. I'm sure you face this patient as firsthand. So when patients like these come to you, I have already given you certain investigation findings that already were there. Please walk us further than that. How would you approach this patient? Shankar sir, we can't hear you. You are muted.
Oh. Good evening
Yeah.
to all. This is a case of bilateral pedal edema and little asymmetry with swollen left lower limb more. So when this is a chronic progressive increase in the swelling, so it is a chronic case, it's not an acute one. So what I see is whether it is pitting or non-pitting, I see initially. So before, so already Dr. Praneeth has already alluded to many cases, many conditions. Those were all ruled out, except looking at the history, progressive swelling, and there is a dull aching pain and hyperpigmentation of both the feet and pitting edema. All these go in favor of chronic venous disease. So whether it is varicose veins or the chronic venous insufficiency, we get it done by ultrasound. And ultrasound also revealed there are perforators in left lower limb. That's why the left lower limb is a little swollen more. And there is a little warmth at the shin. It could be cellulitis, or it can be superficial thrombophlebitis. If it is cellulitis, it may be bacterial cellulitis, or sometimes non-bacterial cellulitis also may be there. So this is a clear-cut case of chronic venous disease, chronic venous insufficiency, and varicose veins on the left side. There is some amount of cellulitis or thrombophlebitis. This is a final diagnosis.
Shankar sir, Praneeth mentioned about proteinuria and renal dysfunction. A normal urine analysis and a normal creatinine, is that sufficient for you to rule out protein losing enteropathies as the cause? Not enteropathy, protein losing nephropathy as the cause, or would you like to explore a little bit more?
Oh, if it is a bilateral pedal edema, we look for any advanced renal disease. There may be serum creatinine may be elevated, or the proteinuria may be there. A nephrotic syndrome or nephritic syndrome, both will cause this bilateral pedal edema.
So you don't think that will be too subtle? You don't think that you have to look at protein creatinine ratio or those kind of things?
That is early, you see, early involvement of proteinuria, microalbuminuria. So here it is a case of diabetes and hypertension. We have to see the USCR, that is urine albumin creatinine ratio. And if it is 30 to 300 milligrams per day, then we say that it is a microalbuminuria. If it is beyond that, then we say it is a macroalbuminuria. But here, because of all the investigations, they reveal that the renal disease, the liver disease, the heart failure, the malnutrition because of the protein losing enteropathy or nephropathy, all these are ruled out. That's why we have come looking at the picture, the progressive increase in the swelling, and there is a pigmentation at the ankle and the feet, dull aching pain, and subsides while lying down and increasing while getting up, and while sitting and standing. So these are all go in favor of chronic venous insufficiency. Then warmth left limb, that may be due to cellulitis or thrombophlebitis. We have to investigate further.
Sir, in these kind of patients, is there anything else you do to go forward with infection evaluation, or you empirically treat them for superficial infection?
See, most of the times we go by empirical treatment, because blood cultures we should send, but at the same time, most of the times this bacterial cellulitis because of staphylococci or streptococci. So the antibiotics which tackle these two organisms definitely will subside.
And what is your go-to antibiotics, sir, at your place in terms of the staph and strep for these cases?
I use amoxiclav and the dalacin, this clindamycin. I use most of the times in these cellulitis of lower limb. Amoxiclav or cephalosporins plus clindamycin I give.
And sir, what is your thought on these compression stockings? Is it something which is practiced routinely? I am asking you more with regard to the practical aspects of prescribing as well as wearing. What is your thought on it? Do patients comply, availability, weather, all those things? If you could just give a little insight.
Here, the treatment by the vascular surgeon is quite different from an internist or a clinician or a physician at our mofussil areas, because we get to only elastic stockings here of different sizes which will fit, will give. That is only from toe to thigh we give elastic stocking. Here that is the only available. Otherwise, that is a creep bandage. These are the only two things, the compression stockings available with us. But at a tertiary level, there are the class 1, class 2, class 3 type of bandages will be there. So the different pressures will be there, pneumatic compressions will be there. So the management at a tertiary care level is quite different from our this peripheral areas, because we have got only one either creep bandage or the elastic stocking. We don't have any graded stockings, graded pressure bandages.
Perfect. Thank you so much, Shankar sir. I will move on. The forum is open for discussion. If anybody has got any questions, comments, either you can raise your hand or put your question in the chat box, and I will address it either through Dr. PC Gupta, or I'll try to answer my best. And while you do that, I will take opinion of Dr. PC Gupta. So, sir, you heard this case and you heard that some of the workup which have been done so far. Shankar sir is almost certain this is chronic venous disease that we are dealing with. Please give us an idea of what you think is going on with this patient.
Thanks, Anoop. So good to be back. You can hear me, no?
Yes, sir, absolutely.
Okay. So fine. Looking at the patient profile, there are two things I would like to look at. One is the edema, which is of recent onset, and pigmentation, which has been there for a many years. So one question that I have for you, what is the patient's BMI?
Sir, I don't have the record in front of me, but if I have to make a reasonable guess, that will be around 27, 28, something like that.
27, 28 is not too bad. But just for discussion's sake, a high BMI or obesity is a cause for skin pigmentation and edema. So
okay.
The second thing, clinically, this seems to be some sort of chronic venous disease. The color Doppler that is there, I find that almost, let's say more than half the color Dopplers that I get from the sonologists, whether in the city or in the hospital, wherever, they are wrong. And I have learned not to rely on them and scan the patients on my own. And quite often I will find that there is a more significant venous problem than that has been described in the report, or vice versa. I have seen Doppler reports where acute DVT has been missed in the upper and the lower limbs. So I would definitely like to do a Doppler on my own to make sure that we are not missing any chronic recanalized DVT. So that is one thing. Second, the color change in diabetics can be a sequelae of recurrent cellulitis. So when these patients get cellulitis, even recurrent or one episode, it leaves behind pigmentation on the skin. So another thing that I would examine in these patients is for the presence or absence of intertrigo between the toes. Quite often, mild intertrigo is a fungal infection, and that is a precursor for cellulitis in these patients, and that can explain the pigmentation. Another thing, I don't know how significant that would be. As physicians, you would know better, but adrenal insufficiency is another cause where pigmentation can be seen, though it may not be just localized to the legs. Chronic liver disease is another area where I see patients, and we've not really evaluated this patient for liver function, but chronic liver disease is another condition where I find patients with bilateral pedal edema and pigmentation. Sometimes they may have dilated veins, sometimes they don't. So that is another thing I would like to look at. As far as renal insufficiency is concerned, I would definitely like to go beyond a serum creatinine and a urine routine examination to look for any proteinuria. Chances of proteinuria would be rather less because she is already on telmisartan, and that should have taken care of any proteinuria if it was going on. This is how I would like to proceed for this patient. Lymphedema, theoretically a possibility, but lymphedema is classically, it's a clinical diagnosis. I don't need any investigations to do that. If you see a hump over the foot, or you see a thickening of the skin, or you see squaring of toes, then it is lymphedema as the primary cause of edema in that patient. So I'll stop here so that we can discuss, because I'm sure there will be some comments or questions on to what I have said, and I think that would be a better way to proceed.
So, sir, you please stay unmuted because I have gathered few questions both from the discussion that we had so far and also what you have shared your thought. But in the meantime, I also ask my attendees, if you have any questions, then you can put it on the chat box. So, sir, I start with where you left. The clinical diagnosis of lymphedema or clinical diagnosis of nephrotic syndrome or venous insufficiency or whatnot. We have all been reading gravity-related dependent swelling is mostly either venous insufficiency or it is heart failure. Nephrotic syndrome, it typically affects the periorbital areas, it is generalized, or you have got lymphatic system, which is non-fitting, which is stiff, which is toe sparing, and all those things. They are good clinical entities for us. The problem is we never get black or white patients. We get patients who are either too early on the disease, either too late on the disease. They may have done some treatment by themselves, or either knowingly or inadvertently. So my question to you is, how reliable is our clinical diagnosing methods to differentiate between venous disease versus cardiac disease from the swelling particularly that I'm talking about? Can you simply looking and examining can rule out lymphatic disease particularly early in the course, and for that matter nephrotic, for that matter liver disease and whatnot? Sir.
So Anoop, what I would say is we would definitely have a clinical lead by looking at the legs and by feeling the legs. It would be really impossible to be absolutely certain, except in case of lymphedema, which has sort of set in, where there would be dermal thickening. So if you pinch the skin, you find that it is thick. That is definitely lymphedema. It can be secondary to chronic venous insufficiency. So, I mean, then we call it phlebo-lymphedema, but lymphedema would definitely be there. So when I look at these patients in my clinic and I see bilateral edema and the legs appear shiny and the edema is sort of significant, extending up to the knees or even beyond, I straight away think of a medical cause for edema and not a venous cause directly. Then I would think of whether it is heart failure or is it liver disease or is it proteinuria. It has to be one of those. And then we would definitely evaluate based on those to identify what might be the cause. So clinical, while not absolutely sure, it's a very, very good lead you can get by looking at the legs and just pinching the skin.
Right, because the reason why I asked you this question is because, I mean, we all practice that way, right? We get clinical history and examination, we take the lead and then we further go ahead. The reason why I asked you this question is that when patient categorically mentions that there is gravity dependent edema, then I sometimes ask myself that am I turning a fool of mind by ordering a urine protein in that patient? Because nephrotic syndrome or nephrotic swelling typically would not cause a gravity dependent edema, or you think it can fool us?
It can, because there are many times when we've seen mild edema involving just the lower limbs and patient says, oh, I'm okay when I get up in the morning, but it increases during the day. So any edema will increase with gravity. So when the patient is lying down, the whole thing may not go away, but on dependency, any edema will increase, whether it is nephrotic syndrome or whether it is liver related or it is cardiac related, gravity will worsen the edema.
Then one other thing that you mentioned was about you repeating most of the venous ultrasound. Now, Hyderabad has only one C Gupta, but I'm pretty sure Hyderabad is doing hundreds of venous Doppler every day. So as a cardiologist who is working in a different hospital, and I'm sure there are so many doctors here today who are working in different hospitals, how do we know that whether this venous Doppler which is done is correctly or not? Are there any hints that we can take from the report which should make us suspicious about the report?
So I have learned to view each report with suspicion now, and this has come with the experiences that I've had. So when early on in my career, I was treating patients for varicose veins, I realized I was not getting the results I wanted or I should have got. And when I started cross-checking those venous Dopplers, I realized that I had possibly been operating on patients who didn't have venous reflux and leaving alone patients who had venous reflux. So now every room in my clinic has a venous Doppler, and I see no way around that as far as my practice is concerned. The second thing is a lot of venous disease is being treated not only in the city, but all over the country based on one, wrong Doppler reports, based second on no Doppler reports. So you are talking about clinical evaluation. People look at the leg, look at one leg and say they need both laser on both the sides. So that's a totally different ballgame, but it's like a cardiologist. You have somebody in your department who does good echocardiograms and you learn to rely on that person. Would you rely equally on an echocardiogram done by just anybody?
Perfect, sir. I will continue my questions to you. You mentioned about overweight by itself being a cause of hyperpigmentation. Can you elaborate a little bit on that? How does weight correlate with hyperpigmentation?
So what obesity does is it sort of puts pressure on the iliac veins, resulting in venous hypertension. And venous hypertension thereby causes not only edema and pigmentation, but can also cause some venous dilatation leading on to varicose veins forming over the legs and thighs, and even resulting in frank ulceration. There have been a couple of publications where people have stented the iliac veins in obese patients in trying to get rid of this edema or these symptoms, which I think is definitely an overkill and not something that I would justify. But yes, obesity itself is a cause for chronic venous disease.
So the venous compression you are talking about at the iliofemoral level or at a central level?
Iliofemoral, mainly the iliac veins. Iliac veins.
Iliac veins.
Yeah.
Then the follow-up question that comes is, can there be other abdominal pathologies which aren't necessarily malignant as such? We are not talking about cancer and whatnot, but any other abdominal pathologies which otherwise are quite benign but still cause venous compression? Like, can chronic constipation cause venous compression?
I haven't come across that.
And anything else, like should ultrasound abdomen be one of the part of leg
Yes.
swelling evaluation, or is it an
Yes.
overkill?
It is, I think it should be when you are not sort of getting anywhere. Let's say I do a venous Doppler in my OPD. I don't find a cause. Patient already has all these investigations. Clinically, there is no jaundice, no evidence of liver disease. I think ultrasound is something that I would definitely look at. And it may not be just some benign thing. I mean, there are times when we found malignancies or lymph nodes surrounding the iliac veins, which result in edema.
And I'm sure all of us at some point have ratified this May-Turner syndrome and given an exam where we have got positive marks for May-Turner syndrome.
Yeah.
How frequently you diagnose it, and is it always unilateral?
No, May-Turner syndrome was classically described as compression of the left common iliac vein by the right common iliac artery. But then compression can occur due to different arteries at, over different veins. So the iliac veins can be compressed at the common iliac, the external iliac, whether left or right. So classical one is the left common iliac vein, but it can be on either side. And again, it's a diagnosis which is more misused than actually used. And there is some controversy that if we do pick up a patient with unilateral symptoms, do we really go in and fix the May-Turner syndrome, or do we manage with that with compression? So younger patients, we try and manage with compression, because putting a stent in the iliac vein in a young patient doesn't seem to be a good idea. So it is a definite entity. But again, unless it has caused DVT, I can't justify doing anything for it other than compression therapy.
And the diagnosis is by ultrasound only, I believe?
No. Ultrasound is not a great investigation for iliac veins. At the most, it may tell you whether or not they are clotted or patent. So the next best investigation, if you would want something non-invasive, is an MR venogram, which is reasonably good. But if you want the gold standard, then it is an intravascular ultrasound.
Did I hear it correct? Intravascular ultrasound, you said?
That's right.
Oh, okay. How about CT venogram for these cases?
Again, CT venogram is no better than MR venogram.
Okay. Okay. Sir, one question that is asked in the chat box is regarding drugs and medicines, which should be specifically asked. I'm going to modify this question a little bit. We, as a cardiologist, we love to blame all calcium channel blockers for leg swelling. In fact, excuse me. In fact, if any patient comes to my OPD with a drug chart that says amlodipine or cilnidipine, then the first thing I do is without doing anything, I tell them to stop the medicine, come back after 1 month, because there is no diagnostic that is required. It's almost always calcium channel blocker. So my question to you is, are we over blaming these calcium channel blockers a lot? Will a 5 milligram of amlodipine or a 5-10 milligram of cilnidipine, can it cause leg swelling? What is your opinion on that?
Yeah, I think you would see more of these, but yes, I do exactly the same thing in my clinic. When I get patients who are on calcium channel blockers and clinically I'm not really able to fix anything, and the ultrasound that I do in my OPD doesn't show any significant venous disease, I also stop the calcium channel blocker. And many times these patients come back out of 4 to 6 weeks with edema having completely subsided. Yes, it is something that we should definitely look at.
And other than calcium channel blocker, any other medication that you would tell us that we should particularly be at a lookout when we are dealing with leg swelling? Praneet mentioned about diabetic drug.
I think another drug that is commonly prescribed, and that may be being prescribed to diabetics also, is gabapentin or pregabalin. They can cause edema.
Right. So pioglitazones we talked about, and then gabapentin and pre-GABA is almost universal, I believe. A lot of patients, they are on those medications.
Yeah, because of
Uh,
neuropathy, they would be getting.
Right. So I am reading through one of the question, and while I read, I will ask you another question. Sir, this whole thought about crepe bandage and stockings as treatment for or compression, I would say compression therapy as a general. I remember we had a long discussion about it in one of the huddles. If we could just briefly revise it again. And I'm going to give you particular scenarios. Does compression therapy differ between DVT or varicose veins or incompetent perforators, like in this particular case? That is number one. And number two, how do you manage compression therapy in a patient whom you are also suspecting there could be superficial cellulitis? Is it safe to apply compression on the top of that? So two questions.
So we'll take the second one. In case of cellulitis, we generally do not prescribe stockings. So cellulitis is again by and large a clinical diagnosis. And once the cellulitis is treated, or while the treatment of cellulitis is going on, I generally ask the patient to be on bed rest with elevation of the leg. And once the edema comes down, generally they may not require compression. But if you really need to give compression for a patient with cellulitis, I would probably put a cotton roll and then use a crepe bandage or something that we are using now called a high grip bandage, which sort of tends to stay on better with better compression. Crepe bandage becomes loose very early. But I wouldn't apply them very tight, and definitely avoid stockings when the skin is inflamed. Moving on to the types of compression, it is basically the class of compression or pressure at the ankle which differentiates between class 1, 2, 3. So the lowest is class 1, and most of the anti-embolism stockings that you get come in this category. So about 14 to 18 millimeters of mercury. Up to 25 to 30 millimeters of mercury, we are looking at class 2. And then about 35 millimeters is class 3, which we use typically for a venous ulcer. Class 2 would be for varicose veins, due to whether it is due to perforators or just primarily varicose veins. So if we were to look at this patient, I would say class 2 because there is pigmentation and edema, and class 2 would be what I would prescribe for this patient. Now, stockings have certain limitations. One, the way they put them on, that needs to be taught correctly, otherwise patients are absolutely non-compliant. Summers are a bad time for stockings. Then stockings around the foot, I mean, these open toe stockings cause edema of the toes and actually can cause sweating between the toes and intertrigo, leading on to infections. So we need to be mindful of that also. Then many of our patients will have very narrow ankles and very wide calf muscles, close to what we might say an inverted champagne bottle. But then what happens here is we will not get the stocking sized correctly, because the size that is suitable for the ankle will be very tight at the calf. And these patients, when they put on these stockings, actually the venous return is impeded by the tightness of stocking around the calf. And they typically complain of worsening of symptoms, or they develop swelling after they wear the stockings. So these patients, stockings are not the answer. So we would use a bandage, or we have newer compression methods like compression wraps, which use a Velcro, or we have something called aero wraps, which use a Velcro, and we can inflate these devices to class 1, 2, or 3 compression. So a lot more is available in terms of compression beyond stockings now.
Sir, we are going to stay on the topic of compression for some time, because I think this is very, very relevant for everybody who prescribes it. Are all compression stockings graduated? Whichever a patient is going to go and buy off the shelf, are they all graduated stockings?
So if you buy a standard branded stocking, these are supposed to be all graduated compression, which means the pressure is maximum at the ankle. And as we move up, the pressure comes down. And it's logical because that would allow the blood to venous return to be facilitated. the situation that I mentioned earlier, where the ankle is narrow and the calf is tight, then the graduation is lost because the calf pressure becomes a lot more than the ankle pressure. So while the stockings themselves are graduated compression, for this particular patient, it may not serve that purpose because of the shape of the leg.
And then two questions related to particular scenarios. Number one, what is your thought on compression stocking in established acute DVT? Patients whom, let's say if this patient ultrasound would have suggested acute DVT, other than doing traditional management of anticoagulation and whatnot, do you see any role of giving compression stocking in these patients?
So compression is an essential part of treating deep vein thrombosis. So initially, if the swelling is significant, then I would start with a crepe bandage or a high grip bandage. Once the swelling comes down after 3-4 days or a week, then I would prescribe stockings because it's an expensive item. And if I prescribe stockings for the leg when it is swollen, then after a week, the patient would have to change it. But compression, yes, we must institute from day one.
And sir, please walk us through the rationale of that. I mean, the way I think is that venous outflow is anyway blocked with the blood clot. What is compression going to do? And secondly, the cardiologist in me thinks that aren't you putting them at a higher risk of pulmonary thromboembolism?
So the second question, no, we are not increasing the risk of pulmonary thromboembolism. Second, there have been studies which have shown very clearly that if compression is not used, the risk of post-thrombotic syndrome is much higher. And the longer we delay the institution of compression, more the chances that the edema will not go away with our anticoagulation and compression started late. So start compression at the earliest. It reduces the edema. There are obviously venous channels which are open, and that is why the leg has not ended up with venous gangrene.
And sir, the second question about the crepe bandage relates to CABG patients or those patients who had venous harvesting done in their legs. These patients are routinely placed on crepe bandages even before the swelling develops. The assumption I'm guessing is that the venous channel, the major venous channel is taken away. So might well give some compression so that there is no venous stasis. Is there a scientific thought with that, or this is just a practice that we follow?
So I think two reasons. One, when the GSV is harvested, these patients do get some edema, and it's a good idea to control that edema. Basically, it may not really result in venous insufficiency in the long run. Second, whenever there is venous edema, the wound healing tends to be poor, or the wounds will not heal. And these are generally long incisions. And if we control the edema, the healing is much better. So I would use the crepe bandage, if for nothing else, to make sure that the healing is good.
Sir, I'm just reading few of the questions in the chat box. One question is, sir, is a periodic check with vascular team advised for people with varicose veins, otherwise not having any other issue? So that is one question for you, sir. I guess it directly relates to your business. So I know the answer, but I would still like to hear. The question is, patient who have got varicose veins, the obvious varicose veins, but no other comorbidities. Should this patient go for a vascular check routinely, or one-time review is good enough?
So if a patient has varicose veins and there is significant reflux identified in the long saphenous or the short saphenous vein, we would discuss with the patient whether or not he or she would want any intervention. If no intervention, then compression stockings. We generally advise follow-up for 2 or 3 things. One, we like to see if there is any progress of the symptoms. I mean, in terms of pigmentation, the size of varices, and if that is increasing despite using stockings, then we would sort of recommend that it's better to undergo some intervention. Secondly, if I keep a patient under follow-up, I find that the compliance with compression is much better. So if somebody has decided that I want treatment for my varicose veins with lifetime stockings, and compliance becomes important. So regular follow-up would ensure that compliance.
And sir, since we are talking about varicose veins, this Daflon supplementation, how relevant is that? I know that because of its inert nature, it is quite commonly prescribed. But in your clinic, do you see much response with that?
So the maximum benefit comes from the stockings. But we do have patients who say that they felt better when they were using Daflon. Now, I do not know. I mean, there are studies which have been done on Daflon, which are supposed to show or which show reduced inflammation around the ankle in people with varicose veins, also some reduction in edema, and definitely some relief in the ache that comes from varicose veins. So we have prescribed Daflon even for patients who do not have significant reflux, maybe just reticular varices and aches, and they seem to benefit. I mean, personally, it is very difficult for me to say whether it is a placebo effect or really the effect of Daflon.
Sir, one more question which is asked in the chat box, which I think is very, which is as basic as it can get. And you know that most of the time we do very poorly with basic questions. So the question is risk factor for varicosities. So my question to you is, who develops varicose veins? Do diabetics develop varicose veins? Do people who stand for long period of time, or there is some predisposition? What is your thoughts on that?
Okay. So a number of risk factors have been described for varicose veins. So if we look at primary, I mean, there are some, we call something called primary varicose veins or secondary varicose veins. Primary varicose veins are purely due to just valvular insufficiency with nothing else precipitating the varicose veins. And this, I think, is a matter of pure chance or kismat, as I tell my patients, that they have a valvular problem resulting in reflux and varicose veins. Pregnancy is a situation where the varicose veins do develop and behave like primary varicose veins even after the delivery. And this happens because there is a general loosening of all the collagen tissue. And the same thing happens with the perivalvular sort of tissue, and the veins, the valves tend to become incompetent. The secondary varicose veins, which occur due to obesity or due to old DVT or as a result of a vascular malformation, these are obviously explanatory causes by themselves. Now, diabetes causing it? No. Standing causing it? No. So what happens is patients who have varicose veins and they have a standing profession, the symptoms tend to become worse. The veins tend to progress much faster because that is the position in which the venous pressure is maximum at the ankle. But standing itself does not cause varicose veins.
Thank you, sir. I think that is as clear of an answer as I can ever imagine. One last question which came on the chat box is any nervous system disease which can cause edema? I can't think of anything other than nervous system leading to sedentary lifestyle, which may cause more gravity dependent edema. But anything that you can suggest, nervous system disease?
Yeah, there are two mechanisms by which nervous system disease will cause edema. One is, as you mentioned, the sedentary or the patient not walking or sitting for a long time, and that anybody sitting for a long time will develop edema with or without nerve system disease. The other thing that happens is it's very important for venous return to have that peripheral heart functioning or the muscles pumping or the muscles contracting. So if the muscles are not contracting, then the venous return does get impaired, resulting in edema. And this happens not only in the lower limbs, it also happens in the upper limbs.
Sir, it is 8:59. One last question, and then I'll try to wrap up. Any role of giving diuretics in not heart failure patient? Pure edema, we are trying to get rid of edema. Any role of diuretics?
No, they are being misused.
Okay. At this point, if there are any further questions, I'll take. Otherwise, I'll start winding up. Praneeth, I have a question for you. PC sir is skeptical of venous Doppler. He wants to make sure things are as they are reported. What is your take on the echocardiogram? This patient came in with this diagnosis of moderate aortic stenosis. Aren't you curious to know what is the diagnosis? And then second question is, Is there any role of checking BNP in these patient subset to exclude cardiac problem?
So I agree with what Dr. Gupta has said, and I can correlate with that. Like the many a times when you think that there's a discrepancy in the report and the clinical presentations, we do check in ourselves. So this patient, because the symptoms are doesn't suggest of a heart failure, and equally because the clinical examination findings also are not that correlating, probably I will take this report as being good. But if the patient continues to be symptomatic, then I would definitely do echo myself, or I'll walk into the echo room, look at the findings myself. Unless I'm not convinced about the investigation, I would do probing further. Now, as I mentioned earlier, because clinical suspicion is low, I would probably not probe further. I would ask this patient to be on follow-up using these stockings. But if the patient continues to have edema despite being compliant, and if it's not getting better, I would definitely ask a BNP, which is a relatively simple investigation to get it done, and currently it is available easily as well. So maybe that would be next step. Not at the right first instance, probably on follow-up, I would ask BNP if he continues to have edema.
Thank you so much, Praneeth. Shankar sir, you are unmuted. Any final comments you have before we close?
There is one condition we see in clinical practice in the obese women, especially where it is a disorder of adipose tissue. It is patient presents both the lower limbs, the shape of inverted champagne bottle. At the just above the level of the ankle, there will be cut off stopping point, and above that there will be edema will be there. That is lipedema. It's a condition we see in especially in obese women only, especially particularly in women. And the second thing is the pretibial mixed edema. Sometimes we see in Graves' disease, it is a non-pitting type of edema. And the lymphedema, if of moderate to severe, there will be also non-pitting. But in the early, there's a mild edema, mild lymphedema, there will be pitting will be there. And one more thing is before we order for compression stockings or compression therapy, we have to rule out any occlusive arterial disease by ABPI, that is ankle brachial pressure index. We have to rule out this arterial, any peripheral arterial disease is there associated or not, because the compression stockings will aggravate the disease proper. If it is associated with the peripheral arterial disease, that has to be kept in mind. And regarding where patient is intolerant to compression stockings, and because of ulcers or because of the thrombophlebitis or the cellulitis, the compression stockings may be postponed. During that time, we can give these venoactive agents, especially this diosmy flux, then rutosides, then horse chestnut extracts and all. These are definitely in the clinical practice we have seen over a period of 6 months we give, and there will be a lot of symptomatic relief will be there with these venoactive agents. So what we give regularly, the Deflon, the aldosmin, the oxyrutin and all. See, these are my points. And one more, this neurological condition associated with the edema. This is a complex CRPS. This is complex regional pain syndrome. This usually seen after limb trauma, and it is characterized by pain, edema, alteration in the skin and temperature, color. So this is a complex regional pain syndrome. Once we see, we don't forget in our lifetime, that is the patient comes with sensory hyperesthesia, allodynia, then temperature, color, and skin, the temperature, color, as well as pain will be hyperalgesia, hyperesthesia will be there, even allodynia will be there. Even if the light touch also, the patient will be feel very much painful. The pseudomotor, motor, trophic, vasomotor, all these changes associated with this complex regional pain syndrome. So this has to be kept in mind. This is the neurological condition. So and the really autonomic nervous system is involved here. So this has to be kept in mind when the patient comes with the pain, edema, and alteration of skin color and temperature.
Perfect. Thank you so much, sir. PC sir, one last question. What is the standard of practice in terms of checking for arterial system before prescribing compression? I'm interested in knowing particularly also because SGLT2 inhibitors are a very common drug which is prescribed now by cardiologists as well as endocrinologists. And early in the data, when empagliflozin was studied, or canagliflozin rather was studied, one of the red alert finding in this drug class was increased risk of amputation on patients because of undiagnosed peripheral arterial disease. Now that signal was seen in canagliflozin, and over the time with EMPA and DAPA, we did not see that signal. And now we have pretty much stopped thinking about peripheral arterial disease when we prescribe SGLT2 inhibitor. But 3-4 years ago or 5 years ago, that was a very common thought process. So most of our patients are on SGLT2 inhibitors. Now on the top of it, we'll be giving compression stockings. What is the current algorithm? Are we checking arterial system in all the patients?
So any patient who comes to me, or for that matter, any patient who comes to any physician, we should check the peripheral pulses, and that is what we do for all our patients. So if the pulses are felt comfortably, the feels normal volume, I would just stop at that and go ahead and prescribe compression. If the pulses are not felt because the edema is severe or the pulses are feeble, then I would do an ankle brachial index, as Dr. Shankar was mentioning, and then take a call on prescribing a class of compression. Sometimes the patient may need a class 3 compression or a class 2 compression, but I would downgrade depending on the severity of peripheral vascular disease. So yes, we must check the peripheral vascular system before we prescribe compression.
Perfect. Thank you so much. I don't think that we were in a routine practice to do that, but it seems like it is quite relevant. And I think in the era of SGLT2 inhibitor, maybe we need to see this as a resurgence and stop, at least prevent our drugs causing any kind of arterial disease. With this, we are already 8 minutes.
Sorry, one more thing.
Yes, sir.
I think one interesting thing Dr. Shankar brought up was the complex regional pain syndrome. Another neurological problem, just to complete the list, is what we see Charcot's foot. That also there is significant edema. It is obviously clinically clear that it is Charcot's foot we are dealing with, but then again, there is edema with a neurological disorder.
Perfect. Thank you so much. Sir, since you are a surgeon as well, one question I think I can ask you, if you could really brief it up. Cellulitis. When should we send for surgery in our case if patient has got just pure superficial cellulitis? And till what point you think empiric antibiotics is a fair deal?
Almost always, unless you find that the skin is really absolutely shiny, red, there is a lot of swelling, or you find blisters, then I think it's a good idea to involve a surgeon.
Okay. Perfect. Thank you so much, sir. Praneeth, your closing comments for today's discussion, maybe 1-2 more minutes, and we'll be done after that.
Yeah, fairly common symptom, and I believe most of the physicians and surgeons do encounter this common symptoms. And as mentioned, try to look at the systemic causes and come to the local causes. Be mindful that the ultrasound or the color Doppler report that you are seeing may not be completely clear or right. So clinical judgment is something which always has to be kept in mind. And if it is If your suspicion is strong, then probably it is worth repeating. And always trying to get involved your other colleagues, particularly vascular surgeons, to have a look personally to see whether we are having any other issue. And various differentials we have discussed. And the mainstay of treatment seems to be the compression stockings or bandages. And it's glad to know that there are various methods which are available, which will make the compression adequate and equally comfortable for the patient. And the one rule that we understood, which we do miss, is that ruling out a peripheral vascular disease, arterial system, before before prescribing compression stockings is a must. That is a great learning point in today's session. That is the summary that I could get.
Thank you so much, Praneeth, and thank you everyone for attending today's session. Thank you, PC sir, for enlightening with your thoughts. And we will definitely get you again for similar sessions in the future. As you all know, we do this every Wednesday, and this session also will be live online in the next few days. So if anybody has missed or want to revise, they can always utilize their dead time and listen to these sessions. Thank you all. We will see you next Wednesday with a new topic. Take care, guys. Good night.
Thank you. Bye, everyone.